On this episode of the Ask Mike Reinold Show, we talk about evaluation and treatment of biceps pain.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the introduction to performance therapy and training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody. Latest episode of the Ask Mike Reinold Show. We're here at Champion PT Performance up in Boston, answering your questions. I'm here with Dave Tilley, Kevin Coughlin, Lisa Lowe, Mike Scudo, Anthony Vedetto, Lenny Macrina, answering your questions. Anything you want to talk about, sports PT, performance, career advice, head to mikereinold.com, click on that podcast link, and you can ask us more questions. Len, who do we have for a student today? Anybody new?
We have no new students. Gavin's been with us for weeks and
months
weeks now.
Probably maybe months now. Who knows?
It's funny how we have to coordinate our outfits to look the same week after week. We have Gavin Harden from the University of Wisconsin Badgers. And is that Lacrosse, Wisconsin? Is that where we're at? Or is that a different Wisconsin?
That's different. So I'm from Madison, the Badgers.
Madison.
Yeah, Madison.
I just want to say also, I like that Gavin is like a one name person in Slack for us. It's just like Adele. He's just Gavin. There's no last name. It's my
Prince,
favorite.
Madonna, Gavin. Yeah.
I kind of like that. I like that. Gavin's pretty cool. I like it. Gavin, you're doing a great job. I think, your progress with these podcasts are getting better every week. So keep it up. What do we have for a question this week?
This week, Nathan from Ireland asks, I've been a practicing physio for a few years. I have one doctor that tends to diagnose anterior shoulder pain as biceps pain in the majority of her patients. How do you evaluate biceps pain, and how does your treatment change if you feel it is more biceps than rotator cuff?
Awesome. All right. Really good question. I think this happens to a lot of people, right? I think we see this a lot. Biceps pain, tendonitis, tendinosis, common diagnosis with you have anterior pain. I think just selectively with my caseload and who I work with right now, I feel like I've seen that a little bit less lately. But I do remember at one point in time, anytime it was anterior shoulder pain, the doctors would send a script that says biceps pain. So let's talk about that a little bit. Let's talk about maybe the evaluation and figuring this out. But how do we determine this is biceps pain? And before we talk about what we do with it, but is all anterior shoulder pain biceps pain? Who wants to start with that? And I got to ask, Kevin, have you and Dan Pope done your deep dive on this topic yet? I feel like you guys, you've hit most topics by now, but do you want to start this one off?
Sure. Yeah, we did look at this, and Dan had a really good interview with Rob Mansk talking about biceps tendinopathy and
cool.
Kind of asking Rob that question, is this all biceps tendon pain? And kind of what we found when we were looking at things is that they kind of categorize it as there's primary biceps tendon pain, where maybe somebody has a bone spur or a thickening of one of the ligaments in the front of the shoulder that can irritate the biceps tendon. But more often it seems to be secondary. And within that, almost never is the biceps tendon the only pain source in isolation. It seems like there's usually some other pathology in the shoulder, whether it's the rotator cuff or the labrum or something else that's leading to biceps tendon pain. So I guess from an evaluation standpoint is you're just trying to get a lens into when it started and maybe why it started. And at Champion, we obviously see a lot of overhead athletes, and in that population, it doesn't seem like you get a lot of that primary biceps tendon pain. There usually is other things going on, whether it's a very hypermobile joint or a weak rotator cuff or lack of overhead mobility contributing to biceps pain. So I guess from evaluation standpoint is you're trying to figure out why is the biceps taking a little bit more load? What else is going on in the shoulder that's changing the biomechanics to irritate the biceps tendon? And then, some of our special tests, I guess, can aggravate it a little bit, but I don't think there are any great ones for the bicep tendon specifically. Palpation obviously is one, like you could palpate it. And I think with that, it's just important to look at the other side because, I don't have any biceps tendon pain, but if I get in there and dig, it feels really uncomfortable. So you
Sure.
want to make sure that it's not just the incidental finding there. But that's kind of what we came across is it doesn't seem to be something that occurs in a high frequency just by itself. There's often other things going on in the shoulder, and we want to find that primary cause.
I like that. And I think one of the biggest things I got from Kevin there was that there's probably more things going on. So don't take that diagnosis and say, oh, biceps tendonitis, I'm going to do this program, right? No, it's like you have to figure out what else is going on. Before we go too deep, here's a question to the group. Okay, Kevin kind of said there's often other times stuff going on, stuff like that. When is it just an isolated biceps? Because there's always examples, right? There's always times and it's like, what would be an example of you definitely just have isolated biceps pain and it's nothing else? What do you guys think, Dave?
I recently treated like a mid 50-year-old guy who just went hard in the paint on a biceps workout at the gym. He did like hammer curls, supinated curls, preacher curls. And he came in like 2 weeks later. He's like, yeah, I think I like hurt my labrum. I'm like, what'd you do? He's like 9 sets of biceps. And I was like, think it's your biceps, my guy.
Really? So
Yeah.
like long head biceps pain he just had,
Yeah,
and it
just
was
straight
all
up bicep
anterior.
strain. Yeah. Straight up bicep.
Wow.
Or
What I
our
like that.
friend who's a gymnastics coach who lifted a grill into his truck and tore his bicep. Pretty clearly a bicep.
That's a good point. Yeah, yeah, I like that. That seems aggressive though. I mean, that everybody knows a Popeye sign. I like that. What else? What else? I mean, I guess you can have a subluxing long head, right? So you can tear the ligament that goes across the groove, and then
Jorgensen's.
you can have a subluxing biceps tendon. So it is possible. It's funny. I just got back from a big conference with a lot of surgeons, and they when we get to the case studies, they love showing crazy case studies, right? There's never like the normal people we see. It's all these disasters. And I will say, you see some where you're scoping the shoulder because they think it's a slap tear and it looks pretty good, and then they just go up around the corner and they look at the biceps and it's like, oof, that thing looks awful. Like what happened, right? So you never know. And there's one example is really interesting when they brought the person into external rotation, the undersurface of the biceps was actually rubbing on the humeral head and kind of like chafing it. So, I mean, I would say like earlier in my career, I would probably be somebody that would said like, it's never the biceps. And I never like meant it like it's never the biceps. It was kind of just like a rhetorical statement, I guess, like meaning like it's rarely the biceps. But I think a lot of people think like, oh, Mike said it's never the bicep. Like, no, it can definitely be the biceps. It's probably just rare. But all right, sorry, I'm rambling here. So all right, so let's get back to it. So we have biceps, we have that. I would say before we talk about treatment, one thing with special tests, Kevin said there aren't a lot of good special tests, which I would agree, like speeds test, stuff like that. There's not a lot of good biceps tests out there. What I actually do in my exam when I'm looking at biceps pain is I try to rule out everything else in my exam. Right. So I'll try to rule out rotator cuff symptoms, right? Because that's the first thing I tend to jump at is rotator cuff when it's anterior shoulder pain. And if I can rule that out, like there's no near, there's no Hawkins, there's no, full can, empty can discomfort. There's no discomfort with rotator cuff, like manual muscle testing. It's almost like you can rule out the muscles out, that are around that area. So I would just say that as a tidbit, but okay, we have biceps pain. What do we do? Anybody want to hit like what do we do for goal? Because I think they asked, how do you evaluate? How does your treatment change if it's more biceps than rotator cuff was the exact question. So who wants to hit this one? I mean, I don't know. It's probably not a ton different, but what do you guys think?
Sure. Yeah, I can jump back in. I think the biggest thing is to figure out is whether someone's getting like a coracoacromial impingement or they're getting direct biceps overload. So like I think a lot of times people will have overhead pressing or they're throwing a lot or something like that. And like the biceps tendon is getting rubbed and or chafed or irritated along with like maybe the bursa on the front of the shoulder. And so if it's something else that is causing the biceps to get cranky from like a overload point of view, that's very different than someone who is like, the guy who was just going hard in the paint on bicep stuff. I often find almost always it's like the coracoacromial issue more so than the, direct loading. So yeah, you look at all the basic stuff of like soft tissue mobility and strength and, workload management, all that kind of stuff. You have to dig in the weeds a bit to figure out like what is causing this one area of the shoulder to get blown up a bit. And I think it comes down to like a little, can we back off on some of these like, loading exercises? Like, do you have to overhead barbell press? Can you landmine press? Like, why do you have to do a, a lot of those times it's just someone doesn't realize that like 80% of the things they're doing are causing pain. And so little soft tissue work, little modification of stuff, and then like, little posterior cuff work. And these people tend to do okay.
Yeah, and take a step back and go back to what Kevin said, right? Like if this is something that is usually not in isolation, you just take a step back and you start your checklist of things that you find. And most often these are people that I don't want to say beat up. I don't know if that's like the right phrase for this particular population, but they tend to have some motion restrictions, right? Older individuals, maybe they have tight thoracic, mobility concerns. They have loss of glenohumeral mobility, for example, or their rotator cuff strength stinks, right? That sort of thing. Like you're not necessarily doing much to the biceps, right? I mean, I guess you could throw some like modalities at it, like laser and stuff, but like I wouldn't shockwave the long head of the bicep, right? Unless you just really hate your patient or something. That seems terrible, right? But I mean, maybe it'll work if if they're just gonna go home and not use their shoulder for a couple of days. But like to me, that seems like a lot of like work. So yeah, so I'd say big take homes from this episode then. So evaluation treatment of biceps pain. It's not in isolation oftentimes. So take a deeper dig into what's going on with the person, right? Try to figure out if you have any other sources, anything else that may be like occurring, and then just take a step back. And this is just a prime example to me where we shouldn't always just be treating a diagnosis. You should be treating what's functionally wrong with the person in front of you, right? So dig through that, and then I think your treatment plan will kind of like write itself when you start looking at all the things that's probably wrong with the person. Okay. All right, good question, Nathan. Thanks so much. Appreciate that. If you have a question like that, head to mikereinold.com, click on that podcast link, and please subscribe Apple Podcasts, Spotify, so you can keep getting notifications, and we'll keep doing these episodes. Thank you so much.